A very good evening and welcome to the most important class of physiology, that is fluid distribution and edema. Fluid distribution of the human body. It's a very important topic. Once you understand this topic, you will be able to solve many problems related to fluid distribution in our body. You will be able to solve the most common, one of the most common complaints with which patient comes to our hospital, that is edema. One of the common complaints is edema. So I welcome you all to one of the exciting discussions today. You will have to listen to this class very carefully so that we don't miss any point while we are evaluating a patient coming with edema or with blood loss or with water loss, that is dehydration. Many diseases are associated with understanding of body fluids. If you understand this properly, you will be able to solve many diseases, many disease related issues, and you will be able to handle or treat patients properly. So fluid distribution of the body, if you see the total body water is composed of intracellular fluid and extracellular fluid. Intracellular fluid and extracellular fluid. Intracellular fluid is approximately 2/3 of total body water. 2/3 of total body water. All right. Whereas extracellular fluid, obviously the rest, that is 1/3. The extracellular fluid is again divided into interstitial fluid, ISF, interstitial fluid, and the vascular volume. The vascular volume, or also called as plasma volume. This interstitial fluid is 3/4 of the extracellular fluid, and plasma volume is 1/4 of the extracellular fluid. The vascular compartment is composed of blood, which contains plasma, the blood cells, the different types of blood cells, that is red blood cells, white blood cells, platelets, and various other cells. So our vascular compartment is composed of both plasma and also cells. But here fluid is contributed by the plasma. Please remember that we have got these fluids are separated by membranes, and a cell membrane is a barrier for movement of ions, movement of hormones, action of these various neurotransmitters, various chemical components, various hormones, and thus bringing about the physiological balance in the body. There is one important barrier for plasma proteins, and this is capillary wall or capillary membrane. Capillary membrane. So capillary membrane is a barrier for plasma proteins, whereas cell membrane is a barrier for various ions and various other chemical components, which I already just not highlighted. Movement of ions across the intracellular fluid, from intracellular fluid to extracellular fluid, from extracellular fluid again to back to intracellular fluid. This occurs by various processes. An important process here is to understand osmosis. The distribution of fluid is determined by osmotic movement of water. The distribution of fluid, that is total body water, it is determined by the osmotic movement of the water. So what is osmosis? Osmosis is nothing but diffusion of water across a semi-permeable membrane. Diffusion of water across a semi-permeable membrane. Semi-permeable membrane or selectively permeable membrane. Selectively permeable membrane. So how does the water diffuse? The water should move from higher concentration area to a lower concentration area. The concentration of water in a solution is the chief important factor that determines the movement of water. So water moves from higher concentration area to a lower concentration area, and in between we have got a semi-permeable membrane. In between we have got a semi-permeable membrane. So we'll understand this again with the help of a concept of osmolality and osmolarity. But before that, I'll again emphasize on importance of total body water. The total body water, around 60% of the body weight. This is how you calculate the total body water. All right. If a person comes with edema, if a person comes with pleural effusion, if a person comes with accumulation of fluid in the body somewhere, so you should be able to understand in which compartment this water has accumulated, and thus you can give accordingly the treatment, and then you can relieve him from that kind of water accumulation in the body. So to understand this, we need to understand the physiology of total body water. It is 60% of the total body weight. I told you that 2/3 is intracellular fluid, that is 40%, and 1/3 of 60%, that is 20%, is extracellular fluid, which is again divided into the interstitial fluid, which is 3/4 of extracellular fluid, and the blood volume, that is 1/4 of that is a plasma volume, that is 1/4 of the extracellular fluid. So if you calculate this, the total body water, say suppose a person has got a weight of 70 kgs, a 70 kg man. So a 70 kg man, around 42 liters is total body water. How? That is 60% of 42. That is 0.6 into total body water. This is the formula you are going to apply. All right. So the total body water in this case is 42 liters. Out of these 42 liters, 2/3 is intracellular fluid. So around 28 liters is intracellular fluid, and 1/3 is extracellular fluid. Around 14 liters is extracellular fluid. The 14 liters of extracellular fluid is again divided into the interstitial fluid and the plasma. Interstitial fluid is 3/4 of this 14 liters, so it is around 10.5 liters. The plasma is 1/4 of ECF, that is 3 liters. This 3 liters of plasma becomes 6 liters in pregnancy. There is increase in plasma volume in pregnancy. This becomes 6 liters in pregnancy. And because of this, many changes occur in the body of a pregnant lady. There is a gain of, in total 9 months of pregnancy, around 10 to 11 kgs of weight. Partly because of increase in the plasma volume, and partly because of some other reasons. We'll discuss that in a particular chapter. All right. So again, with the help of a pie diagram, let us try to understand the composition of intracellular fluid is 2/3, and the rest is 1/4 of ECF. 3/4 of ECF is interstitial fluid. 1/4 of ECF is the plasma. We still have a small amount of other fluids which are insignificant. All right, which are very, very insignificant. This concept you will understand with the help of this wonderful diagram. This diagram. All right. See, whenever we have got one intake, oral intake or whatever it is, and then we have got output. This is our output of water through kidneys, through lungs, through feces, through sweat, and through skin loss, insensible loss, we call it insensible water loss. Through kidneys, obviously, you know that we excrete urine. Through the lungs, it is humidity, humidified air that comes out. Fecal matter, you know, small amount of water also. A significant amount of water comes out. Sweat, especially in summer. And through skin, the insensible water loss. All right. This is about intake and output. So this intake and output determines the movement of this water across our body. Whenever you the intake from plasma, the water is moving into the interstitial fluid. From interstitial fluid, the movement of water is occurring in the intracellular fluid. From the intracellular fluid, again the movement of water to the interstitial fluid, then again to the plasma. So this is all happening because of an important property called as osmosis. Osmosis is movement of water across the membrane, and movement is what is determining the movement. What is determining the movement is the concentration, high concentration area to low concentration area, and in between we have got a cell membrane. The cell membrane in between the interstitial fluid and the intracellular fluid. The capillary membrane is between the plasma and the So the capillary membrane is between the plasma and the interstitial fluid. Capillary membrane is between the plasma and the interstitial fluid. Movement of water is occurring like that, and then ultimately output. Output is through the various pathways I told you. Now here to summarize, I'm saying intracellular, extracellular fluid. Let us try to understand with the help of this diagram, which shows us a blood vessel containing the plasma. If the diagram is clear, a blood vessel is showing the plasma, which is 1/4 of the ECF. Then just immediately surrounding the blood vessel we have got interstitial fluid, and around that we have got cells. Inside the cell we have got intracellular fluid, which is composed of 2/3 of the total body water. 2/3 of the total body water. All right. So this movement of fluid across the cell, from cell to the interstitium, from the interstitium to the blood, that is occurring via the osmosis. And osmosis has got one important property of osmolarity. In my classes for understanding of fluid electrolyte balance in kidney chapter, acid-base balance, I was discussing this point at that time when I was discussing ADH hormone. Also in endocrinology class I was discussing what is osmolarity. Now let us try to particularly understand what is osmolarity. Osmolarity is nothing but it is the concentration of a solute per liter of solution, or concentration of a particular particle. It is the concentration of a particular agent or particle, say suppose glucose, say suppose some other particle. So concentration of particle per liter of solution. So we have got a solute, we have got a solvent which makes a solution. In chemistry you have read. So this is osmolarity. Osmolarity of a human body is measured by milliosmoles per liter. Milliosmoles, milliosmoles per liter. Milliosmoles per liter. Now how do you compare this with osmolality? Now another important term you need to understand, osmolality. Osmolality is defined as it is the concentration of a particle per kg of water or per kg of solvent. So if it is milliosmoles per kg, or water, you are calling it as osmolality. So please remember, osmolarity is liter of solution, and osmolality is per kg of the solvent. So please remember, who is determining the concentration gradient here, or who is determining it, is the number of particles. All right. Say suppose we have got a compartment like this, theoretical compartment with a membrane. On one side of compartment you are calling it as compartment A and compartment B. Say suppose on the compartment A side we have got multiple solute particles, and on the compartment B side we have got only few particles. It is the number of particles which is determining. So greater number of particles on the side A gives greater concentration or greater osmolality or osmolarity to compartment A. In between these two compartments, if you have got a semi-permeable membrane, in between these two compartments, if you have got a semi-permeable membrane, then the movement of water starts. The aim of this process of osmosis is to bring about the concentration on both the sides equal. Both the sides of the membrane should become equal. So we know that on the A side we have got lot of particles, on the B side we have got few particles. On the A side we have got high concentration area, B we have got low concentration area. So what happens is, a solute, it does not easily cross a membrane. Please remember, it is an effective osmole or osmotic force of the water is created here because of this high concentration and low concentration gradient. This osmotic force makes the water to move across the membrane. It can be a capillary membrane, it can be a cell membrane, or this membrane can be any of any example. Please remember. So now the movement of water is occurring from A side to B side. All right. So please remember that sodium is an important example here. If you talk about sodium ion, sodium, it is not able to penetrate a cell membrane. It cannot move outside or inside a cell membrane unless and until you have ion channels. Last time I told you there are voltage gated ion channels for sodium especially. So but sodium cannot exactly move out of the membrane on its own. It cannot diffuse out of the membrane, but it can cross a capillary membrane. All right, a cell, if you talk about, so this is a cell with a cell membrane. So a sodium ion cannot move out of the cell, but at the same time you have a blood vessel here. The blood vessel has got a capillary membrane. So this is dashed line is a capillary membrane, say suppose. Sodium, if it is present here in the interstitial fluid, it can easily cross the capillary membrane and enter into the blood vessel. And sodium can similarly move out also. So sodium can easily cross a capillary membrane, and hence sodium can be called as an effective osmole of capillary or vascular compartment or extracellular compartment. So it's an effective osmole. Osmole is nothing but it is a solute which is determining the concentration across the membranes, right? So we have got certain extracellular solutes in our practice, clinical practice. Patients come to us, so you check what is known as, you are able to check the sodium concentration. All right, you are able to check the potassium ion concentration in the blood of that patient. You are able to check the anions like chloride and bicarbonate in the blood of that patient. So cation concentration, anion concentration. You are able to also determine the nitrates. So blood urea nitrogen of the body fluids, and creatinine of the plasma blood sample that you have taken, and you are also able to determine the glucose. So these are the important extracellular solutes which we are able to check in the patient's blood, and these solutes are actually moving across the membrane and changing the concentration or osmolarity of that particular compartment. If they are high or low, they create a lot of disturbances in the movement of the body fluid. So similarly, a person comes to you with edema, feet, and it might be because of excess of sodium. We all know that aldosterone, it causes sodium and water retention. So it might be because of increase in aldosterone pathway. So many reasons are there. You need to rule out one by one and thus treat the patient appropriately. To rule out this, you need to understand what is osmolar gap. What is osmolar gap? Osmolar gap is nothing but it is the difference between the measured concentration and estimated concentration, or it is a difference between the measured osmolality and estimated osmolality. So it is the difference between the measured osmolality and the estimated, what is normal estimated osmolality. For example, if you want to consider if you want to calculate the ECF osmolality gap, osmolar gap. So ECF, what is the estimated osmolality? Estimated osmolality of ECF, that is milliosmoles per liter. The ECF osmolality is calculated by 2 times the sodium concentration in milliequivalents per liter plus glucose in milligrams percent divided by 18 plus urea divided by 2.8. So this formula gives us the fact that so this formula helps us to understand, all right, this formula actually helps us to understand the estimated osmolality of the ECF. Now the basis of calculation is that sodium, why you are taking 2 times sodium in this formula? Because sodium is the most abundant osmole in the extracellular compartment. I told you it's an effective osmole because its ability to movement across the capillary membrane. It is the most effective osmole, it is the most abundant osmole. That's the reason why we are taking 2 times the sodium is doubled here, because it has got a positive charge, and for every positive charge it will attract a negative anion, that is chloride. It will attract an anion along with it. All right, so because it is attracting an anion along with it, you are giving 2 times, you are calculating the sodium concentration here. The convertible factors 18 and 2.8, this is calculated based on the there is a conversion factor for milligrams per deciliter. All right, so we are here detecting the milliosmoles per liter. So to determine the osmolar gap, you have to make these changes in the equation so that you understand the ECF osmolar gap. All right, once you find any abnormality, you will come to a conclusion that there is some problem in the ECF concentration. There is some problem with the ECF concentration. All right, hope you understood the concept. Now let us try to understand the most important aspect of today's class, that is the Darrow-Yanet diagrams. Darrow-Yanet diagrams. Now these diagrams will come in your exam. These diagram problems will come in the exam based on this diagram. We'll try to understand what is normal first, then we'll try to understand what are the abnormalities. Please remember that how the body osmolality or concentration of various solutes in the body, that is the intracellular volume and extracellular volume, they are changing according to some clinical conditions. To understand this, it is very easy for us to put the body fluids in the form of a graph with y-axis and x-axis like this. So we take volume on the x-axis, all right, and concentration of solute on the y-axis. Volume on x-axis and concentration of solute on the y-axis. And then when we determine it like this, 2/3 is ECF and 1/3 is ICF. We all know. I'm sorry, I told you opposite. So 2/3 is intracellular fluid and 1/3 is the extracellular fluid. Say suppose this is the total body water. The solid lines that I have drawn here, the solid lines which I have drawn here, this is a controlled state. And if suppose any change in the ICF, say suppose change in the ICF, that is volume of the ICF is increasing, and the concentration is decreasing, you can mention it like this. So that causes decrease in the concentration, decrease in the volume of ICF. So ICF volume has moved like this, the ECF volume has moved in this direction, and ICF volume has increased in this direction. Something like, I'm giving you just an example. So a decrease in the osmolality, according to this diagram, decrease in the concentration of solute means decrease in the osmolality. So height of the fluid compartment has come down in this diagram. Height of the fluid compartment has come down means there is a decrease in the osmolality or decrease in the concentration of the solute. If the decrease in the concentration of solute and extracellular volume, what is the impact? The extracellular volume also has decreased, but what happened to ICF? Intracellular fluid has increased. So please remember that extracellular volume, it always enlarges when there is a net gain of fluid. So when you put IV fluid in the patient, there is a net gain of fluid. Whenever there is a net gain of fluid, which is the volume which is first expanding? It is the extracellular volume. You should remember these principles to understand the clinical problems related to fluid electrolyte balance. I repeat again, the extracellular volume expands whenever there is a net gain of fluid in the body. The extracellular volume also decreases whenever there is a net loss of fluid in the body. Say suppose because of diarrhea, vomitings, or because of some accident, person has lost the blood. Because of some surgery, the person has lost the blood. Because of delivery, a lady has lost a lot of blood. So which volume is decreasing? It is the ECF. It is the ECF which is the decreasing. Okay, all right. Next, how is the concentration of solute determining? Please remember the concentration of solute here is nothing but the body osmolality. At a normal condition, the intracellular concentration of water equals to the extracellular concentration of water. The cell membrane is not a barrier for water. All right, because water can easily move. So at a normal condition, the ICF concentration of water, ICF concentration and ECF concentration, both are same at a normal condition. Intracellular volume, the ICF, the volume, it varies with effective osmolality of the extracellular compartment. So solutes and fluids which enter into the extracellular compartment, for example, because of sweating, diarrhea, which leave the extracellular compartment, loss of a fluid from the extracellular compartment because of diarrhea, because of profuse sweating, because of fluid restriction and all. What happens is the intracellular volume is altered if the extracellular concentration changes. Intracellular volume gets altered only if the extracellular volume changes. If the extracellular volume, the concentration of the extracellular fluid increases. So what do you mean by that? Height of the compartment increases. If the concentration of fluid, extracellular fluid increases, the cells lose water and they shrink. And if the ECF osmolality decreases, the cell gains water. So in this diagram, what's happening? The concentration has decreased. See, this is the concentration decrease. From here it has come to here, decreased. So what is happening to the ECF volume? It has shrink. So please remember, whenever there is loss of osmolality, the cells shrink. Whenever there is gain of osmolality of the ECF, the cells get swollen. All right, this point you have to remember. We'll try to understand various illustrations of Darrow-Yanet diagram of volume and osmolality. Will make differences, and we'll try to analyze in patients what kind of changes have occurred. All right. So say suppose a patient shows a loss of extracellular volume with no change in osmolality. All right, what will happen to the intracellular volume? A patient shows, say suppose a patient shows, so let us try to understand with the help of the diagram here. On the y-axis we have concentration, on the x-axis we have volume of water. We all know that the ICF is 1/3, ICF is 2/3 and ECF is 1/3. All right, say suppose there is no change in concentration, but only ICF fluid loss has occurred. So volume of ECF has decreased. Volume of extracellular fluid has decreased. What will happen to the intracellular fluid? There is no change of intracellular fluid. There is no change in the intercellular, because concentration is not decreased, concentration of solute is not, concentration level is remaining same. This concept, this is termed as isotonic fluid loss. This concept is termed as isotonic fluid loss. That is, the body has lost equal amount of water and solutes. For example, because of polyuria, isotonic polyuria, or because of hemorrhage. In hemorrhage also, this is the earliest finding in hemorrhage, or as an early finding of diarrhea and vomitings also you find this. So, but major example is hemorrhage. So solute concentration has not come down, but the volume has come down of ECF. So ICF is normal. This is first important Darrow-Yannet diagram. Next important Darrow-Yannet diagram we'll try to understand. We have got on the x-axis we have got volume, and on the y-axis we have got concentration of the solute. This is the normal ICF and this is the normal ECF. Now let us try to understand with another diagram. Say suppose in the next scenario, say suppose there is a loss of extracellular and intracellular volume with a rise in osmolarity. With a rise, concentration has increased, but there is a loss. So what are the important causes here, or what could be the pathology here? For example, I will show you with the help of this diagram. Here the concentration has increased and there is loss of water of both ECF side and ICF side. So because of loss of water both on ECF side and ICF side, concentration has increased. This is particularly seen in diabetes insipidus. Particular finding of diabetes insipidus. So here we need to understand that the patient here is showing loss of extracellular fluid and loss of intracellular fluid also. But what is happening to the solute concentration? Solute concentration has moved up, means increased. Is it not? On the graph it has moved up in this direction. So the dashed line is showing the disease aspect, all right? Am I audible properly? Yeah. So, so this diagram is representing that there is a net loss of water from the body. Net loss of water from the body, it occurs because of important physiological reasons, like if you're not drinking properly, if you're not drinking the water properly, so poor intake of water. If you're drinking less water, poor intake of water is an important physiological concept here. Or sometimes profuse sweating in a hot weather, summer, profusely you are sweating, and there is a pathological condition I already discussed, that is diabetes insipidus. In case of diabetes insipidus, what happens is there is loss of hypotonic water. So free water or hypotonic water loss, that results in retention of solutes in the body. Because of this, what happens is there is a net loss of water from the body, with solutes are increasing, they are not getting excreted, and hence it is resulting in increase in the concentration of the solute. Next example we will try to understand. Now third example. In this third example, say suppose a patient is gaining extracellular volume of extracellular volume of water. At the same time, there is a rise of osmolality or shift of water out of the cell. All right. At the same time, there is a rise of osmolarity or shift of water outside the cell. What does that mean? It means that there is a net gain of water, there is a net gain of solute, not water, I'm sorry. There is a net gain of solute, that is increase in osmoles or particles. I told you what is a solute, what is a osmolarity at the time of discussion of osmolarity, I told you. So here say suppose a person is taking, for example, person is taking lot of salt intake, eating lot of salt in the form of some food or some junk food or spicy food or whatever it is. Or if the person is given certain drugs like saline injections, saline, IV fluids you have put, or sometimes like mannitol is infused. So in this condition, what will happen is the patient will show a gain of extracellular volume, increase in osmolarity, but there is a decrease in intravascular volume. So say suppose, for example, if this is the x-axis, this is the y-axis, we all know that this is the ICF and this is the ECF. All right. A person has taken a lot of solute, so his extracellular solute concentration has increased, because of which the volume has also entered. So extracellular volume has increased. So this is ECF, is it not? Extracellular fluid volume has increased and also concentration has increased. At the same time, what will happen is intracellular concentration of solute also increases, but the intracellular volume gets depleted. It is reducing. So ICF is losing water, ECF is gaining water. ICF is losing water, ECF is gaining water. This is seen in salt intake. That's the reason why we say that salt intake should not be advised to the as a whole. Though it makes the food tasty, at the same time it is removing water from the ICF and it is increasing the water of ECF. It does not remain like that only. We have various physiological mechanisms which bring about normal changes in this, and you know, these things get settled quickly. But to get this settled, person develops hypertension and all various other disorders. So whatever it is, in this, one important point is ICF is losing water, is it not? So if you are giving mannitol, a drug mannitol, or if IV fluids, high concentration of IV fluids are given, not isotonic, hypertonic solution, hypertonic saline or hypertonic solutions are given. All right. So this causes rise in ECF volume, rise in concentration of the ECF. At the same time, ICF volume is reduced. There is a condition in stroke. What happens is, cerebrovascular accident, what happens is there is brain edema or cerebral edema. Because of this cerebral edema, the person develops a lot of confusion, delirium, paralysis will be very, very high. So to treat this condition, you have to give mannitol. You have to give mannitol. So you have to give mannitol. To treat this condition, you need to give mannitol. And mannitol causes what? Removal of this cerebral edema. That is, decrease in the volume of ICF, is it not? Here intracellular fluid means fluid from the brain cells. Fluid from the brain cells or cortex, cerebral cortex. Removal of the water from the cerebral cortex. So this is how, with this concept, our mannitol is acting. Next, we'll try to understand a concept wherein there is net gain of the extracellular volume. Extracellular volume. Patient, next we'll try to understand one more condition wherein a person is gaining water. A patient has gained water in the extracellular compartment or also intracellular compartment. But this time the concentration of solutes has decreased. For example, so this is the ICF, this is the ECF. All right. So there is gain of water on both the ECF compartment and ICF compartment. ECF, ICF. But along with this, there is a loss of solute concentration. Hence, the height of the graph is coming down. So patient is showing an increase in the extracellular fluid, increase in the intracellular fluid, but there is decrease in the osmolarity. The fall in the osmolarity has shifted the water into the cell. Shifted the water into the cell. Shifted the water into the cell. Please remember this point. So what is the consequence? As a consequence, what's happening is there is a net gain of water in both the compartments, ICF and ECF. Here, say suppose the example here is a person who is taking excess of water intake, drinking lot of water unnecessarily, bottles and bottles of water, liters and liters of water he's drinking, because sir has told in the class we should low water intake is causing contraction of the ECF, so I'll drink a lot of water. He'll think and he'll land up into a condition called as polydipsia. Polydipsia is increased thirst. Psychogenic polydipsia we call it. Sometimes patient is on certain drugs which will increase the thirst. Antipsychotic drugs will increase the thirst. So pathologic primary polydipsia or psychogenic polydipsia, the patient feels that he is having low water in the body and starts drinking. Or sometimes you have given excess of IV fluids. Unnecessarily you have given your patient lot of IV fluids, or dextrose, saline, IV fluid, or one more example is, I already discussed this, it is syndrome of inappropriate ADH. All right, in this also what happens is the extracellular fluid volume increases, but the solute concentration comes down because of loss of solute from the body, through the kidneys. All right, because of inappropriate ADH, a lot of ADH is secreted and that causes loss of fluid. Is there any problem with the streaming of the video? Let me check. Yes. Is there any problem with the streaming of the video? No. So in this example, there is net gain of water both in the ECF and ICF. Let us see the next example. Let us suppose a patient shows an increase in the extracellular volume without any change in the osmolarity, without any change in the concentration of the solute, and without any change in the volume of the intracellular compartment. For example, I'll draw a diagram like this and I'll show you. So the ICF volume is intact. This is the normal ICF concentration and this is the normal ECF. So in this, a person is showing increase in the extracellular volume. In this, a person is showing increase in the extracellular volume, but no change in the solute. All right, increase in the extracellular volume, but there is no change in the intracellular fluid volume or concentration of both extracellular and fluid and intracellular. So what's happening is here there is net gain of ECF without any change in the solute concentration. Net gain in the ACF without any in the ECF is gain of isotonic fluid. When does it occur? It occurs if a person is given isotonic IV fluids, and sometimes it occurs if the person is suffering from hyperaldosteronism, causes water retention in the body, Initially what will happen, sodium and water retention occurs, but again sodium, I told you that sodium moves easily in the extracellular compartment. Sodium is moving easily from the blood vessel to the interstitial fluid, and this movement of sodium but not of water results in net gain of water only, and this is seen in because of action of the aldosterone. All right, this is one important scenario you need to understand. Next important scenario let us talk is, say suppose a person is showing a decrease in the extracellular volume and osmolarity. So for example, again our graph, Darrow Yannet diagrams we are discussing actually. These diagrams will be given in your exam. All right, this is ICF and this is ECF. So next example is a person is showing decrease in the ECF volume, decrease in the ECF osmolarity with an increase in the intracellular volume. So how does that happen? Whenever there is a rise in intracellular volume as a result of decrease in osmolarity, this may happen. So decrease in the extracellular volume and osmolarity. So like this. What happened? Sorry. Yeah, I'm back. So this is occurring because of net loss of hypertonic fluid from the body. Because we have lost solute from the body, the concentration of solute has come down. Because of this, the ICF volume, the more water has moved from high concentration area to the low concentration area. We know the water moves from high concentration area to the low concentration area, and that results in net gain of water in the ICF. This is seen pathologically in adrenal insufficiency. So because of adrenal insufficiency, there is net sodium loss and water loss from the body. So this water loss and sodium loss reflected by decrease in the ECF volume like this. Decrease in the ECF volume like this. All right. So let us now summarize what we have read in the form of ECF volume, body osmolarity, ICF volume. Three things we have read just now. And we are discussing these three things considering the fact that what's